Hi, my name is Jessica Leonard. I am the dietitian for the Pediatric Cystic Fibrosis and Lung Transplant programs here at Boston Children's. And I'm going to take some time today to walk us through what the nutrition management is for both of these patient populations. So what is cystic fibrosis? I'm actually not going to go through this slide in too much detail with you because I'm sure you'll have done it with other people, but it is something that I usually go through with other nutrition students and other dietitians here at Children's, just to give them an idea of the spectrum of disease that they may see in the cystic fibrosis population. So on the right here, we have a graphic that's showing the breakdown of really that 1 in 4 children, when you have a carrier mother and carrier father, are going to have cystic fibrosis. Now, we obviously know this is not a guarantee that 1 in 4 will, but we know that there's a 1 in 4 chance. So just as some quick statistics, about 30,000 people are living with cystic fibrosis in the U.S., about 70,000 worldwide. There are approximately 1,000 new cases of cystic fibrosis diagnosed each year, and nearly half of the CF population is currently greater than 18 years old. So this is, I always tell everyone, the bottom corner here where it says 44 years, that is the current life expectancy of a cystic fibrosis patient, most recently updated in 2017, so waiting for those 2018 statistics to come out. And I always tell everyone this is my favorite slide to update every year because you can see that it just gets older and older that these patients are living, which is an exciting time for all of us to be in. And just as another note, about 75% of people diagnosed with cystic fibrosis are diagnosed by the age of 2. So why is nutrition so important in cystic fibrosis? Hopefully you are aware that this is important already. I'm always going to say that nutrition is important in any patient population, but we know that there is a correlation between patients who are at the 50th percentile for their BMI and improved lung function. So this is not a causative, and this is how we explain it to parents. It's not that if they get to the 50th percentile, they will never have any respiratory issues, but we know that the two things do correlate. And that's through analysis of data from the CF Foundation registry that we've been able to see this over time. So we really push to try to get our patients' weight for length or BMI percentile to be as close to the 50th percentile as possible. And you can see here this graph is kind of just going off into the right. It's not to say that if you are at the 100th percentile BMI that you'll have the best lung function ever, but that's just the way the graph was constructed for this particular study. So what are some of the GI and nutrition manifestations of cystic fibrosis? This is also a favorite slide of mine because it really walks you through all of the different places that you're going to see CF be in the body of these patients. And I will say that when I learned about CF in school, it was really about it's a pulmonary disease and it also means that their pancreas doesn't work. And you can see here that it's really many more things than that. So I like to kind of call out what we consider to be the GI or nutrition manifestations of cystic fibrosis. The one that people are most familiar with is pancreatic insufficiency or sufficiency, and whether they are actually releasing those pancreatic enzymes into their intestine for digestion. We definitely have patients who have a lot of gastroesophageal reflux disease. We see incidents of delayed gastric emptying. Meconium ileus is something that we see in infancy, often followed by those patients being more prone to DIOS or distal intestinal obstructive syndrome, cases of rectal prolapse, intussusception of their intestines, high incidence of constipation, some patients who are having hepatobiliary disease, pancreatitis. We're doing a lot more looking at what role small intestinal bacterial overgrowth is playing, and also fibrosing colonopathy, which is not something that we see as often as we used to, and was really associated with some of the ways that the enzymes used to be prepared for these patients. But you can see here by looking at the graphic on both sides that it's really hitting across the board of all of the different organ systems. So, what is the role of the registered dietitian in all of this? Really, our overarching goals are to monitor growth and nutritional status in our patients. We provide nutritional counseling and education, and we're also looking to address and support any feeding issues. As we follow these patients over time when they're infants, we're really typically dealing with what we want to say are more normal baby feeding and growing issues. So at that point, a lot of their challenges are not so much specific to cystic fibrosis, but just that we're really keeping such a focus on their nutrition. And the graphic here in the bottom left is actually from the CF Foundation, and you can see I've called out the dietitian, and they really consider this to be one of the required team members of the cystic fibrosis team, knowing that nutrition is playing such a big role in their long-term survival. All right, so the patients that we see in the hospital are typically patients who have pancreatic insufficiency. So in this graphic above, you can see you have the pancreas, you have the pancreatic duct. There is basically a mucus plug that is plugging up that duct, so that typically when you would eat, your food would move through your stomach, get to your intestine, send a signal to your pancreas, and your enzymes would be released. So with that mucus plug there, the enzymes are signaled, but they're not able to get through into the small intestine to promote digestion. So let's take a closer look at pancreatic insufficiency and digestion. It's going to sort of hit a couple of different systems in digestion. The first is the pancreas that we were talking about previously, that those enzymes are not able to get out because of the mucus plug. So therefore, digestion of fat, carbohydrates, and proteins are impaired. And then you can also see the hepatic duct there is coming down into the intestine. And in patients with cystic fibrosis, their bile flow through that duct is sluggish. So therefore, the bile delivery is impaired, and that can also cause issues with fat digestion. And you can see here on the bottom is just sort of a walkthrough of a infographic that is talking about what is actually in that pancreatic juice, or that those enzymes that are not coming out, and then also where the crossover comes with the bile and the bile salts and how that affects digestion of fats. All right, so what are, other than being able to look at the cross-section of the body like we were in the last slide, what are some signs of fat malabsorption in our patients? So in our pediatric patients, we're typically looking at having very frequent stools, can be more than 3 a day. Things that are kind of bulky or foul smelling. Now, this is definitely a difficult question to ask families because it's not like stool really smells good, but you will find that as patients get older and parents get more savvy, they'll let you know when something smells worse than normal. Also seeing any stools that might be kind of oily or have some oily residue to them. If the patient is stooling into the toilet, if it's something that's floating, signifying that there's more fat in there. If they're having any gas or stomach pain, distension or bloating, or if their growth is just not good. So they may be eating, but if they don't have enough enzymes on board to help with the digestion of that food, they're not going to absorb those nutrients, and therefore they're going to have poor growth. We can also see low vitamin levels. Again, with some of the vitamins that are fat soluble, those travel with the absorption of fat, and therefore if the fat absorption isn't there, then those levels are going to be low. And also another sign can be a really ravenous appetite. So similar to, as I was saying, in the poor growth category, they could be eating a lot but not gaining any weight because they're just not absorbing those calories. All right, so what is pancreatic enzyme replacement therapy? So we've sort of framed out what the problem is here, so how do we address it in these patients? And this graphic above is one that I pulled from Instagram, and I just think it's kind of funny that this is how this family has decided to dispense their enzymes for their child. So pancreatic enzymes, the components, they contain lipase, amylase, and protease. So the lipase is going to break down fat, the amylase is going to break down carbohydrates, and the protease is going to break down protein. These are porcine derived. They're enteric coated to survive the stomach, and they are meant to dissolve at the pH of the small intestine. So on the left there, the larger capsules you can see, you have the gel cap, and then the little beads that are inside. So those beads themselves are enteric coated, and what is inside of those beads is actually what we're looking to use for digestion. So what are our goals in pancreatic enzyme replacement therapy? We're really looking to mimic normal fat absorption. We know that PERT isn't going to achieve 100% absorption for these patients, but our goals then are going to be to deliver these enzymes to the right place in the right condition at the right time. So the right place means that we want them to arrive in the duodenum or proximal jejunum in the right condition. So we want them to avoid being denatured from stomach acid, and at the right time. So we want them to be taken or delivered in conjunction with the nutrients that are coming out of the stomach into the intestine. On the bottom right here, you can see that this is another graphic from the CF Foundation, that about 87% of people with cystic fibrosis take pancreatic enzyme supplements. So let's look at these enzymes a little bit closer. On the right-hand side, you can see that the two main brands that are used specifically in our hospital, but in most centers, are Creon and Zenpep, and they come at different values. So the number there on the top right, the Zenpep 25,000, means there's 25,000 units of lipase in each capsule. So you can see in this graphic that they've opened those capsules up and taken the beads out. So the beads that are inside of the Zenpep capsules are actually a little bit bigger than those on the right-hand side, where you can see they opened up the Creon capsules and the beads inside there are a little bit smaller. And the values are a little bit different. So you can see for Zenpep there, they have a 10,000 value, but Creon has a 6,000 value or a 12,000 value. So that's something that we as the CF dietitians are more than happy to navigate with you and review dosing on an individual level with the patients. But let's kind of walk through the basics here. So your dosing limits. So the maximum that you want to look at is having 2,500 units of lipase per kilo per meal or per feed. So you're using that, as I said, the Zenpep number. That number signifies the amount of lipase that's in there. You're dividing it by the kilos of your patient to understand how many they're getting. And the other limit that we're looking at is to have try to stay under 10,000 units of lipase per kilo per day. We're going to give these to our patients orally for infants, and this can be from day of life 2 or 3. We're going to open up the capsule. We're going to put the beads into a little bit of applesauce, and we're going to feed them to the patients by mouth. So you can see on the right-hand side, that bottom left capsule, the Creon 3000, the 3,000 value cap is the one that we typically start for patients. That does actually come in the Zenpep brand as well. For children, they may continue to take their beads in the applesauce, but as they get older, we're going to work with them to learn how to swallow the gel caps with the beads inside. We really want to make sure that the patients are not chewing these enzymes. So those beads that are inside are enteric coated. Once that coating is kind of cracked off, if they were to chew them, once that hits the stomach, then they're going to become denatured, and then we haven't got them where we want them to be. In the right place at the right time. All right, so let's walk through a dosing example here. I'm going to do this fairly quickly for the sake of the recording, but I'm always happy to go through it with you in more detail. So in our example here, we have a 15-year-old male with cystic fibrosis, pancreatic insufficiency, and poor weight gain. His weight today is 51.9 kilos, and the reason that we're thinking about looking at his enzymes is that he's had some poor weight gain and also some intermittent abdominal pain. So currently he is taking a meal dose of 4 capsules of the Creon 24,000. So that's the 24,000 units of lipase in each of those capsules. And typically we also have them do a snack dose. Sometimes it's about half the meal dose. Sometimes it's a little bit bigger depending on the size of snacks that they're taking. So 3 capsules of the Creon 24,000 is this patient's snack dose. So first we're going to check and see what his dosing comes out to right now. So at the 4 capsules at 24,000 units of lipase per capsule, that brings us up to 96,000 units of lipase per meal. When we divide that by his weight at 51.9 kilos, it comes out to 1,849 units of lipase per kilo per meal. So the question we're going to ask ourselves is, can we increase the dose? So on the last slide there, we had said that our maximum is 2,500 units of lipase per kilo. So that's definitely below the about 1800 that he's at right now. So let's try and do an example of what we would get to if we went up by 1 capsule. So instead, we're going to do 5 capsules at 24,000 units of lipase per capsule, which is going to equal 120,000 units of lipase. When we divide it by his weight of the 51.9 kilos, that means his dosing would be 2,312 units of lipase per kilo per meal. So at that dose, we're underneath the maximum dose of 2,500 units of lipase per kilo. So we could definitely do that. But one of the things that we want to keep in mind when we're doing PERT dosing is also the role that weight is playing in the dosing. So if we were to think about the same patient and give him a weight of 41.2 kilos, so you're going to need to write this one out because I don't have a slide for you on it. And if you were to have the same patient take 5 capsules of the 24,000, so same thing brings you to 120,000 units of lipase per kilo, 120,000 units of lipase, and we're to divide by a weight of 41.2 kilos rather than the 51.9, then your dosing would come to 2,912 units of lipase. So by taking the weight off of this patient, we just bumped over the 2,500 units of lipase per kilo maximum that we were trying to stay underneath. But you may actually have a patient who is eating the same amount of food. So it's just another way to kind of check what you're doing. Sometimes what I'll do is look at what my ideal body weight would be for the patient and check the dosing that way and see if it still bumps over that 2,500 units, and then decide if it's something that we would recommend. And if we are going to go over, which some patients do just require more enzymes, then that's always going to be a conversation that myself as the dietitian and you and as the doctor are going to have together to decide if we think it's appropriate for the patient. All right, so question time. True or false? Not taking enzymes is a good way to treat constipation because stools gets looser when you take enzymes. The answer is no, this is not a good way. Not taking your enzymes can definitely increase the risk of constipation and can also decrease GI motility. So next question here. I have a bowel movement every day, so I can't be constipated, right? I like to add the right on that one. So let's think about that one for a second. And the answer on this one is also false. What can happen sometimes is that patients may be stooling every day but may still have some constipation in their intestine and are actually stooling around a hard stool ball that needs to come out and likely needs some medication to help with that. All right, last question. My doctor told me I have a working pancreas, or I'm pancreatic sufficient, so I have a normal GI tract. So I haven't talked much about the pancreatic sufficient patients here. So here's our question. Is their GI tract completely normal? And the answer here is also false. They're definitely still prone to constipation. That CFTR mutation is expressed throughout the entire GI tract, and their pancreas can also be sensitive to injury. We do have patients that can do what we call convert from being pancreatic sufficient to being pancreatic insufficient, and this can happen at any age. I've definitely seen it happen in toddlers, but we've also seen it happen in some of our young adult patients as well. So what are the nutritional recommendations for patients with cystic fibrosis and pancreatic insufficiency? We're going to always keep a focus on vitamin and mineral supplementation. As I mentioned earlier, when you have impaired absorption of fat, you're also going to have impaired absorption of the fat-soluble vitamins, because those two things travel together. So we give our patients a water-soluble formulation of those same vitamins. So your fat-soluble vitamins are your A, D, E, and K. And the couple of brands that we use are one called Aqueduct and another one called MVW Complete. So we're happy to give recommendations. They're a little bit different on dosing based on age and brand. So often these patients also need additional vitamin D. Being here in the Northeast, we don't have as much exposure to the sun, and then we do always recommend that our patients wear sunscreen, as we would for any patient. And by wearing sunscreen, you're not getting that vitamin D synthesis from the sun. Also, calcium and iron, we often need additional for these patients, partly because the water-soluble formulations of the vitamins don't have these included in them, and also because we're looking at bone health for these patients, being the additional calcium and iron that they need just to grow. One thing that we do supplement outside of the vitamins for patients is salt. So we know that CF patients are going to lose a little bit more salt when they sweat. And therefore, in the infant stages, because the breast milk and formula and even baby foods don't tend to have a lot of salt in them, so we do a fixed amount of salt supplementation for the infants from 0 to 6 months, and then also from 6 to 12 months. So we can always give dosing for those. After that, what we typically tell families to do is to liberally salt the foods. So they can either salt the food itself, or one thing that some of our families will do is salt the plate and then put the food on top of it. So the first thing they're getting is not that super salty bite. And then we also are going to counsel them to increase salt intake with increased activities and any increased sweating. So often as we're in the springtime, we start to remind our patients that as they move into the summer, this is something to keep in mind, as well as also just plain being mindful of hydration. All right, so next is thinking about our diet recommendations for patients with cystic fibrosis. The things we're looking for are a high-calorie diet, high-protein diet, a diet that's liberal in fat, and also high in salt. So when we think about calories, we're looking at about 1.5 to 2 times the required calories of a non-CF patient. We're also assuming that some malabsorption is still going to happen even though the enzymes are on board. We're thinking about increased needs based on an increased work of breathing, and we know that infection, both active infection and recovery from infection, is going to require additional calories. From protein, we're looking for about 1.5 to 2 times the requirement as well, and looking to repair any damage and also to strengthen the immune system through that intake. Liberal fat is to counteract the malabsorption that we know is happening. Again, even though the enzymes are doing their best, we tend to sort of put a little bit more in so that what's absorbed gets us to where we want to go. And then we're always going to recommend a diet of high salt for our patients because we know that they're going to lose more salt from their skin when they sweat. So for young kids under 1 year old, we actually give the family a prescribed amount of salt to take. And for kids over 1, we tell them to liberally salt their foods. One thing that's really important as we move to the right-hand side here is thinking about trying to create a meal pattern. And this is something that typically kind of emerges around 1 year old or so as solid foods become more of a component of their meals and their bottles or formula or milk are becoming less of a component. So our goal is going to be to have 3 meals a day and about 2 to 3 snacks per day. And we think about those snacks, we want those to be sort of mini meals. We want regular meal times to have limited distractions. We encourage our families to have a family dinner where the patients can experience modeled behavior around eating. And then for those snack times, trying to keep something that is nutrient dense. So pairing foods similar to having peanut butter with some fruit, having crackers with some cheese, having veggie sticks and hummus to dip it in, or fruit with yogurt on top. Some of the high-calorie additives that we turn to help boost the calories in our foods are household things like butter, margarine, or oil. You have about 45 calories per tablespoon in each of those foods. So cheese has got about 100 calories per ounce, obviously depends a little bit on the type of cheese. Heavy cream, about 50 calories per tablespoon. And this is something that we'll have families add to whole milk to boost the calories. Or if they're doing oral supplements similar to Pediasure, we can have them add a tablespoon of heavy cream to that as well. Powdered skim milk is another additive, avocado, peanut butter, mayonnaise, and then we get more into our commercial additives. So one called DuoCal that's got both fat and carbs in it, something called Beneprotein, which is an additional protein supplement, and Benecalorie, which has protein and fat. And you can see on the right-hand column there the different calories that you're getting from each of those foods. One of the other things that we recommend are high-calorie oral supplements, things like Pediasure or Ensure, also Carnation Instant Breakfast, which is a packet that you can add to whole milk, or something called Scandy Shake, which is not around quite as much anymore, but definitely gives a lot of calories in a small volume by adding both whole milk and ice cream to that. The PediaSure is something that we'll turn to with the younger kids, but also really keeping a focus on making sure that they're still eating foods and not just drinking PediaSure. Enteral nutrition support. One of the things that we will recommend if we have not been able to get the patients to that desired 50th percentile by oral diet alone is to think about placing a G-tube. And this is something that, depending on the patient, we may start the conversation early, sort of feeling that the patient may be trending in that direction, or it may be in a more acute setting in a period of acute weight loss and illness. So one of the things that we like to say is that we do get report back from families that having a G-tube in place does help support their growth and take some of the pressure off of needing to take in 100% of their required calories by mouth. There's a lot of different approaches when it comes to G-tubes. You can provide up to 100% energy needs. You can provide daytime feeds. You can provide overnight feeds. They can run continuously, or they can also be provided as a bolus feed. These are going to require ongoing monitoring of the formula composition and their growth, really close monitoring of any reflux or vomiting so we can understand their tolerance, and also the actual surgical site itself is going to need to be followed by the gastroenterology team. For patients who are not able to tolerate enteral feeds into their stomach, we would then turn to a J-tube. And typically what we'll do is a GJ tube. So you have the G portion, you can see in the bottom right-hand corner of the slide, is going to go to the stomach, and the J portion is going to go past the stomach into the jejunum, or this sort of first section of one of the first sections of the small intestine. So it bypasses the stomach and keeps the formula from being able to pool in the stomach and come back up if the patient is having either reflux or vomiting. It does provide a level of lung protection as well. This is something that we typically think about for our both pre and post lung transplant patients, knowing that there is a correlation between reflux and rejection. One of the downsides of the J-tube feeds is that they need to run slower and longer to get the same volume in, but that's also a time where we may adjust the calorie concentration of the formula in order to get them the calories they need and still allow them some time unhooked from their feeds. All right. So one other thing, this is fairly new device that we've been using, is something called Relizorb, and it is an immobilized lipase delivery cartridge. All right, on the right-hand side there, you have the bag of enteral formula with the tube coming out of it, so that's your intact formula. Then you can see there the purple and white cartridge that's added to the tube. That has got lipase inside of it, so that when the formula moves through that cartridge, the fat is broken down by the lipase in the cartridge, and then the feed that comes out has the fat already hydrolyzed in it for the patient. So one of the upsides of this is that the lipase remains in the cartridge, so this doesn't add to their dosing of lipase per day. You can use one cartridge per 500 mLs, but can also stretch it to as far as 1,000 mLs. There are some rate limitations here, so typically looking at 24 mLs an hour with a max rate of 120 mLs per hour. And the max rate is the more important thing here, because higher than that, it's not going to get hydrolyzed by the lipase in the cartridge. This is not compatible with any of the formulas that contain fiber, and that's going to be all of our food-based formulas as well. And the percentage of fat hydrolysis in the formula varies, but typically is still generally within the same range. One thing that we do here at Boston Children's instruct our patients is that this does not replace their oral enzymes. You've heard me talk about the lipase that is within that cartridge. And when patients take their oral enzymes, they're also getting amylase and protease. So the amylase to break down their carbs and the protease to break down their protein. So we don't want to remove the opportunity to have the amylase and the protease on board to help with digestion and absorption of these components of the feed, especially if the patients are going to run a high volume of feed. We don't want them to miss out on any of the calories, the fat, the protein, the carbs that are contained within it. All right, so next I'm going to give you a brief overview of pediatric lung transplant. Indications for lung transplant are pretty varied. Here at Children's doing pediatric lung transplant, we have seen a wide variety of patients. Those who have cystic fibrosis are sometimes our lung transplant patients. pulmonary hypertension, congenital heart disease, interstitial lung disease, surfactant protein deficiencies, bronchiolitis obliterans, and then also patients who are here for retransplant. And you can see on the right there is just a graph kind of breaking down the age and the stratification of the different indications for transplant. Our pre-transplant goals are going to be to maximize their nutritional status, to minimize any infectious risks, to help the patients adhere to their therapies, and also for them to be doing physical and or pulmonary rehab. The components of lung transplant nutrition management are going to be very similar to what we've talked about for cystic fibrosis. We're keeping a close eye on both weight and nutrition intake. We are often providing enteral nutrition support for these patients, whether by a G-tube or a GJ tube. That, as I mentioned before, the post-pyloric access provides lung protection. So in the post-transplant period, we're almost always doing post-pyloric feeds. We're keeping an eye on reflux and rejection, knowing that those two things are linked together. Also thinking about gastroparesis or delayed gastric emptying, knowing that it is an artifact of the surgery that they've undergone by having lung transplant, that their vagal nerve gets manipulated and can result in some delayed gastric emptying. For our cystic fibrosis patients, we're also keeping an eye out for development of cystic fibrosis-related diabetes, and for our non-CF patients, they are also susceptible to steroid-induced diabetes. And then one of the big things that we do from a nutrition standpoint, from the education, is to do education on food safety in the post-transplant period, in that we know that food is a source of infection, so we want to do everything we can to minimize the risk of infection. And so therefore we're really careful about how we wash certain fruits and vegetables, how we cook our meats, and how long we keep foods in the fridge before we consider them to have gone bad, because we know we're working with an immunocompromised patient. All right, so those are all my thoughts on these two subjects. I'm happy to answer questions outside of this presentation, and feel free to email me or grab me when you see me, and we can go through it. Thanks.